Have you ever wondered what it's really like inside a high-stakes surgical consultant exam? Well, today we're going to do just that. We're going to walk through a full viva, tackling a complex case all the way from the initial presentation to managing a really tricky post-op complication. Let's dive in.
So here's how we're going to break this down. We're going to follow the exact path you'd take in a real exam, starting with the clinical scenario, figuring out the diagnosis, laying out the surgical plan, and even handling a major complication. Then we'll finish up with the key takeaways you absolutely need to remember.
All right, picture this. The exam has just started. The examiner lays out the opening scenario. This is that moment where you need to listen really closely for those key words and start building a picture in your mind.
Okay, so a 55-year-old with abdominal pain, flushing, diarrhea, but what's the real keyword here? It's MEN1. That single piece of history is the golden ticket. It immediately helps you narrow down the possibilities, and you know that's the first test from the examiner. Did you spot the critical link?
Right. This is where you can really shine. The examiner isn't looking for you to just throw out a random list of diseases. No, they want to see a structured, logical thought process, starting with what's most likely and working your way down.
And there's the question. The examiner has focused you on small bowel tumors. Your response has to be crystal clear, organized by what's most probable, with a quick justification for each one.
My primary differential diagnosis would be a malignant small bowel tumor. And given this patient's history of MN1 and those classic symptoms of flushing and diarrhea, a neuroendocrine tumor causing carcinoid syndrome is right at the top of my list. But you have to be thorough, so I would also consider other malignant possibilities like adenocarcinoma, lymphoma, and a gastrointestinal stromal tumor, or GIST, each of which has its own set of clinical and biochemical clues.
Okay, so we've laid out the list of suspects. Now, the examiner wants to see how you'd use specific tests to systematically track down the culprit and confirm your leading suspicion. The examiner is pushing for the specifics now. It's not good enough to just say, I'd run some tests. You need to lay out a really precise biochemical and radiological plan. My investigation would kick off with biochemical markers. First, I'd order a serum chromogranin A. It's a sensitive marker for neuroendocrine tumors, even if it's not totally specific. Critically, I'd also get a 24-hour urinary collection for 5-HIA, which is a metabolite of serotonin, to really nail down the diagnosis of carcinoid syndrome. And a pancreatic polypeptide level would also be relevant here.
So, after we get that biochemical confirmation, I'd move on to imaging. A high-resolution, triple-phase CT scan of the abdomen and pelvis is absolutely essential to find the primary tumor and check for any liver metastases. But, and this is crucial, because these tumors express somatostatin receptors, you need a functional scan. Something like an octreotide scan, or even better, a dodapet CT scan, which is just more sensitive for finding the primary tumor and seeing how far the disease has spread.
The diagnosis is confirmed. Now we get to the heart of any surgical exam, the operative plan. What are you actually going to do in the operating room? This is the moment to really show your surgical competence. The examiner is looking for a clear, step-by-step description of the operation that shows you understand the principles of cancer surgery. The definitive management for our resectable small bowel neuroendocrine tumor is surgery. So, after getting consent and doing the proper preoperative workup, I would perform an exploratory laparotomy. The procedure involves a systematic exploration of the abdomen, isolating the segment of bowel with the tumor, and then doing a segmental resection along with a formal regional lymphadenectomy. And finally, of course, I'd restore bowel continuity with an anastomosis.
And a really key detail here is the resection margin. For a malignant tumor like this, you have to follow oncologic principles. That means taking at least 5 to 6 centimeters of healthy bowel on either side of the tumor to make sure you get a complete curative resection.
Ah, and here it is, the classic viva pivot. The examiner is testing your foresight. Do you understand the medical side of things, not just the surgical? This is the kind of question that separates a good candidate from a great one.
That's an excellent point. Since this patient will very likely need long-term therapy with a somatostatin analog, like octreotide, I would absolutely perform a cholecystectomy at the same time. Why? Because octreotide is known to cause biliary stasis, which dramatically increases the risk of gallstones. Doing the cholecystectomy now prophylactically saves them from a future and potentially much more complicated operation down the line.
You know, no operation is without risk. And a huge part of any senior surgical exam is showing that you can recognize and manage complications when things don't go according to plan.
And here's the new challenge. The patient has a serious complication.
The examiner wants to see a calm, systematic response. This is where having a structured approach is just absolutely critical.
The very first step in managing a fistula is to classify it, and we do that primarily based on its output. A low-output fistula is anything less than 200 milliliters per day, while a high-output fistula is more than 500 milliliters per day. And this classification is so important because it's what dictates your whole nutritional management strategy.
My management would follow a very structured approach. First, stabilization. You resuscitate the patient with fluids and correct their electrolytes. Second, sepsis control. Find and drain any collections and start the right antibiotics. Third, nutrition. For a high-output fistula like this, you're going to start total parenteral nutrition, or TPN. Then, investigation to map out the fistula's anatomy, and finally, meticulous skin protection to prevent the bowel contents from destroying the skin.
Now, the timing of what you do next is so important. The initial approach is always conservative management, and we'd give that a trial for about 3 to 6 months. You see, a lot of fistulas will close on their own. In fact, about 90% of those that will close do so within the first 5 weeks. But if it persists beyond that 3 to 6 month window, well, then definitive surgical resection becomes the necessary next step.
And that concludes our scenario. Now to wrap it all up, the examiner will often leave you with a few memorable pearls of wisdom, the absolute must-know ideas from the whole discussion. You really need to remember this. Carcinoid syndrome is a systemic disease. It's not just a lump. Your management plan has to deal with the hormonal effects before, during, and after surgery. It's all about treating the patient's physiology, not just cutting out a piece of anatomy. And this just perfectly illustrates a fundamental surgical truth. Of course, it's essential to know how to manage a fistula, but it is so much better to prevent one in the first place. Meticulous surgical technique, gentle handling of tissues, and making sure you have a tension-free, well-vascularized anastomosis, those are the keys. The best way to treat this complication is to never let it happen.